Good evening to everyone and welcome to today's wonderful evening with Dr. Murli Bharadwaj. A very happy Sri Ramanavami to all of you. Lord Rama is known for the virtue of truth. Even INICET, NEET PG examiner is looking for the truth in your answer before he gives you the seat, doctor. So, with that preamble, let's make the great beginning. Pallavi, Priyanand, Meghaswana, and many more who are all online. Can you please punch? Is the voice loud and clear? So today we'll take around 100 questions, which are all case study, clinical vignette-based questions. Case study, clinical vignette-based questions on the most high-yield topics for the upcoming exam. Nice to see Anamika Sharma from Kolkata and many more who are all online. So whether it is Sri Ramanavami, Ugadi or Diwali, you are the first priority, doctor. At least 1 hour, hum sab milke jara padhai kare to. Most of the things are all there in the score app, the video library and all. But unless we all meet together and study for a while every day, that keeps us all going and going. So thanks to all of you for attending, Rafi, Raj and everyone. So let's make the great beginning, doctor. The most high-yield topics we create exactly. If you look at the NEET PG question paper, 80% of questions are all clinical. So you need to train and tune your mind. Keep punching your answers, doctor. I also have circulated the PDF of these questions we are discussing now. Cough and fever. He has history of COPD. He is tachypnic. pH is 7.36. PaCO2 is increased to 60 and PaO2 is 50. And bicarb is 32. What is the most likely cause of his hypoxemia? So what is very important clue in this given clinical case is inflammatory lung injury that can be because of infection, trauma or other causes. Alveolar arterial gradient, whenever it is elevated, that is very typical of ARDS because of the impaired gas exchange and ventilation perfusion mismatch is what you need to remember. Now, 65-year-old woman, history of lung cancer, diffuse crackles on lung auscultation. Crackles is a very important clue. And once more, you can see PaO2 is 55, pH 7.42. What is the most likely cause? So it is the interstitial lung disease because diffuse crackles in the lung is a very important clue in this question is what you need to remember. Nice to see Rajendra, Narayan, Biswal, and many more who are all online. So, doctor, a 40-year-old man with a history of alcohol abuse, confusion, tachypnea, decreased level of consciousness. He has a fruity odor to his breath. Fruity odor to his breath, very important clue. And pH is acidotic. PaCO2 20, PaO2 80. What is the likely cause of this hypoxia? So it is the methemoglobinemia, especially that fruity odor of his breath is a very important clue. Methemoglobinemia lead to leftward shift of the oxygen dissociation curve, impaired oxygen delivery to tissue, leading to an elevated alveolar arterial oxygen gradient is what you need to remember. So what is the most common symptom of a ruptured abdominal aortic aneurysm, doctor? So it is the abdominal pain. If it is thoracic aortic aneurysmal rupture, then into the interscapular area, there is a shooting pain is what you have to remember. So severe abdominal pain is the most common symptom of a ruptured aortic aneurysm. If it were not to be ruptured, then asymptomatic is the most common presentation is what you need to remember. So what is the appropriate management of a ruptured aortic aneurysm in the abdomen? So we need to do emergent open surgical repair. So if you look at the aortic aneurysmal rupture, DeBakey classification, Stanford classification is the basis to classify. But in the case of once it got ruptured, it is not just dissecting but ruptured, then emergent open surgical repair is considered to be the management. Which is the factor that increases the risk of rupture in an abdominal aortic aneurysm? A lot of times in an elderly person, due to atherosclerosis, presence of abdominal aortic aneurysm is a normal finding. But, very good, Meghasvana, Pallavi, everyone, keep punching your answers, doctor. That is a beautiful way you can actively involve in the discussion. Right, doc? So now, my question goes to you. What factor increases the rupture? In fact, all of them, smoking, hypertension, male sex, advanced age, any of them can increase the risk factor. What is the most appropriate screening method for the abdominal aortic aneurysm in a asymptomatic male patient aged 65 to 75 years with history of smoking? Most of the times in the abdominal ultrasound, the moment the size is more than 5.5 centimeters, that becomes an indication for, please remember, it is 5.5. The other day we had an MCQ in the exam, 5.5 centimeters. So what is the recommended screening interval in an asymptomatic male who has an abdominal aortic aneurysm? So the rule is generally every 5 years. If he is alive, every 5 years is the recommended screening interval is what you need to remember. Now, it is not a risk factors for the abdominal aortic aneurysm. All of them, hypertension, male sex, advanced age, obesity, they're all considered to be the risk factors. If you look at melanoma, what are A, B, C, D, E criteria which is not a part of it? So, asymmetry, border irregularity, diameter more than 6 mm. Similarly, the evolution, they're all considered to be the part of the criteria. It is the variation in the color, not uniformity, non-uniformity is included under ABCDE. What is the most important factor to predict the risk of melanoma progression and metastasis? So it is the Breslow's thickness, which is the most important factor. The thickness of the tumor is the strongest predictor of the likelihood of the metastasis is what you have to remember. So what is the next step to manage in a patient who has got a suspicious pigmented lesion on the skin? So we need to remember punch biopsy. So punch biopsy is the most appropriate next step. Excisional biopsy is not recommended as the initial biopsy method because it will remove too much of the tissue and it will obscure the diagnosis is what you need to remember. Now, what is the first step in the ABCDE approach for the trauma management, doctor? Always airway, breathing, circulation. So airway management is the First thing to basically do, which is not included in the ABCDE approach, doctor. So airway assessment, breathing, circulation, environmental control. So actually environmental control should be the answer. Environmental control is not included in the primary survey. The primary survey mainly focuses on airway, breathing, and circulation is what you need to remember. Now, what is the most appropriate next step in the management for a patient with suspected spinal cord injury after trauma? So it is the immobilization of the spine is the most important next step in the management whenever after a road traffic accident if there is any suspicion of a spinal cord trauma is what you have to remember. Very good. So can the online students can punch? Is the voice loud and clear for all of you, doctor? Now, what is the mechanism of action of apixaban? So it is an inhibitor of the platelet aggregation. It is a glycoprotein 2B3A inhibitor that blocks the binding of the fibrinogen and other ligands to the platelet receptors is what you need to remember. Now, what is not an indication to the use of apixaban? We use it for unstable angina, non-ST elevated MI, ST elevated MI, percutaneous coronary intervention in all these scenarios, not in DVT. In DVT, you use more of an anticoagulant than an antiplatelet agent is what you have to remember. So what is the most common adverse effect of apixaban? Obviously, it is antiplatelet. That's the reason all antiplatelet drugs carry the risk of bleeding is what you need to remember. Which is not a common cause of acute abdomen. Ovarian cyst rupture, pancreatitis, cholecystitis, appendicitis, any of them can lead to development of acute abdomen, as all of you know very well. Whenever acute abdomen is there, we do all this inspection, auscultation, percussion, palpation, fundamentals of our age-old clinical methods. What is the initial imaging modality whenever you are suspecting acute abdomen, doctor? Earlier days, it used to be X-ray, but CT scan. CT scan is the most appropriate, most sensitive, most specific than the abdominal X-ray or ultrasound, as all of you know very well. Especially, sometimes retrocecal appendicitis-like conditions, you may miss them on simple X-ray, or ultrasound, but picked up on the CT is what you have to remember. What is the most common cause of blunt abdominal trauma? It is the motor vehicle accidents very commonly is the most common cause. What is the initial management priority in a patient who has got a blunt abdominal trauma in whom the vital signs are unstable? You need to do first resuscitation, stabilization. They're very important. So secure the airway, restore the blood pressure and oxygenation, control the bleeding, etc. are important. So whenever there is any deceleration trauma, what is the most common injury pattern whenever there's a deceleration pattern? It is a splenic rupture. Spleen is in a very vulnerable position, unprotected position. That's the reason it is the one which is the most commonly injured organ in the deceleration trauma to the abdomen. 28-year-old comes to emergency after getting a gunshot wound. There's a small entry wound in the left lower quadrant, no exit wound found. Fast exam show fluid in the pelvis. What is the next important step in management? It is a CT scan of the abdomen and pelvis. It is the next best step in the management is what you need to remember. If the CT scan is positive, then we need to do exploratory laparotomy is what you have to understand. Very nice to see 13 online classmates. Please inform all your friends. So, 35-year-old male comes to emergency after being stabbed in the right upper quadrant of the abdomen. He is hypotensive, heart rate is 110. There's a small entry wound, no exit wound, fluid in the abdomen. What is the next step? Here we need to do exploratory laparotomy. Because if he is unstable patient, penetrating abdominal trauma, positive fast exam, then there is no more waiting, watching. Exploratory laparotomy is considered the best method. 22-year-old, shot in the abdomen, hemodynamically stable, small entry wound, no exit wound, fast exam is negative. Then what is the next appropriate step? Here, because fast exam is negative, observation and serial abdominal exams, they are considered to be a good way to evaluate. So, this algorithm you need to be good with, doctor. 30-year-old pregnant woman presents for routine prenatal exam. Her last menstrual period was 12 weeks ago. No significant medical history. Her abdominal circumference 30 centimeters. Why you want to, or what could be the reason for the small abdominal circumference measurement? So, typically any disproportion between the last menstrual period and the abdominal circumference possibilities can include placental insufficiency, metal hypertension, smoking, anything that lead to IUGR is what you have to remember. Now, doctor, a 40-year-old male with a history of alcohol abuse comes to emergency with abdominal pain and distension. His abdominal circumference is 120 centimeters. What is the most likely diagnosis, doctor? 40-year-old male with a history of alcohol abuse, obviously non-pregnant, increased visceral adiposity. You need to think about NASH, non-alcoholic fatty liver disease, especially with the history of alcohol abuse. 35-year-old pregnant woman, her LMP was 32 weeks ago. History of gestational diabetes, her abdominal circumference is 38. What could be the reason for her large abdominal circumference? So typically it is the fetal macrosomia, typically that complicates gestational diabetes mellitus is what you have to remember. So, yeah. So nice to see Kavita, Mithuna, Meghasvana, and many more. Very good, doctor. Now, COPD, shortness of breath, ABG show pH 7.24, PCO2 is very much elevated, bicarbonate is 31. What is the likely possibility? So, first of all, 7.24 is acidosis, doctor. Right? 7.24 is acidosis. And because PCO2 is elevated, it is a respiratory acidosis where person is not able to ventilate properly. That's what you need to remember. 45-year-old female with a history of kidney disease with weakness, fatigue, and confusion in ABG show PCO2 of 50, bicarbonate of 28. What is the most likely possibility? So once more, a low bicarbonate is an indicator that it is metabolic acidosis. 38-year-old male with hyperventilation, numbness and tingling in his hands and feet and muscle twitching and alkalotic pH is there, PCO2 is low. So what is the diagnosis, doctor? It is respiratory alkalosis. Because PCO2 is low, pH is high means whenever respiratory alkalosis is there, they travel in opposite direction, right? pH is elevated, but PCO2 decrease. So, 65-year-old male with history of diabetes presents with a non-healing ulcer. Ankle brachial index is measured to be 0.4. So what is your diagnosis? It's a classical story of peripheral vascular disease leading to low ankle brachial index is what you have to understand. Intermittent claudication, ABI is found to be 0.9. What is the management? So commonly smoking is a very important risk factor for the peripheral vascular disease. So the ABI is only slightly reduced in this given case. So that is the reason smoking cessation is most important step to prevent the progression is what you have to understand. So now, doctor, can the online students can punch whether the voice is loud and clear and broadcast smooth? Yeah, can you please punch? Is voice clear and broadcast smooth? Very good. Thank you, Kavita, for the feedback. So, 70-year-old male, history of hypertension, hyperlipidemia, acute onset left leg pain, paresthesia, ABI is measured to be 1.2. What do you want to do? So, here it is not atherosclerosis which led to the narrowing down, but it is a sudden onset. So, elderly person may, what is the cause of ABI, doctor? 1.2 is higher. So, whenever there's a non-compressible vessel because of calcification, which is very common, especially with hypertension, hyperlipidemia, acute onset of leg pain and paresthesia means you need to think about embolism is the most likely cause. Heavy and prolonged menses, uterus is enlarged, tender. What is the next step in management? So, abnormal uterine bleeding always is associated with anovulation, hyperestrogenism, leading to the development of endometrial hyperplasia. So endometrial biopsy need to be done. Irregular menstrual bleeding, abdominal pain, PID, cervical motion tenderness, adnexal fullness. What do you want to do? What is the most likely diagnosis? Ovarian pathology, commonly ovarian cyst. Even pelvic inflammatory disease also can present like tubo-ovarian abscess, which can be like ovarian cyst. But nowhere in the options given pelvic inflammatory disease is not given. So the most likely possibility is ovarian cyst. 55-year-old female presents with postmenopausal bleeding. History of tamoxifen used for breast cancer. Uterus is normal in size, no cervical tenderness, no adnexal tenderness. What is the best management in this given case? So, tamoxifen, what do you like to call it as? SERM. What is that called as? SERM. Selective estrogen receptor modulator. It is anti-estrogen in the breast and pro-estrogen on endometrium. That's the reason you need to do endometrial biopsy. 20-year-old female, 10 weeks pregnant, history of missed period for 2 months. Ultrasound show intrauterine gestational sac, no fetal pole. What is your diagnosis, doctor? So it is a classical case of missed abortion. Embryo or fetus died but is retained within uterus. And it presents with vaginal bleeding, abdominal pain, but there is no passage of tissue. That is a very, very important clue. 35-year-old female presents with heavy vaginal bleeding and cramping. She is 8 weeks pregnant. Cervical os is dilated. There is passage of tissue. If passage of tissue, and how is the cervical os? Os is dilated. So, vaginal bleeding, passage of tissue, and a closed cervix that may have opened during the passage of tissue, they're all indicators of complete abortion. Fever and foul-smelling vaginal discharge 2 days after undergoing abortion. Obviously, there are septic conditions in which abortion occurred. That's the reason there is a foul-smelling vaginal discharge, which is the important clue, doctor. Very good. Am I audible, doctor? Is the online broadcast fine? Can you please punch? Is the voice loud and clear without any break and interruption? Can you please punch? A 24-year-old woman presents at 10 weeks of gestation. She is looking for an elective abortion. Her vital signs are normal, no medications. The next step in the management will be watch. Perform an ultrasound to reconfirm the gestational age. A lot of times, for a disproportionate or abnormal gestational age, what are the most common cause? Wrongly informed last menstrual period is the underlying cause. So before you proceed to any elective abortion, it is important to confirm the gestational age of the fetus using a ultrasound is considered to be a very important clue. Thank you, Nitin, Mithuna, Kavita, Megasvana, for updating me that the voice is clear. Because now I'm broadcasting from the home, always there is an insecure feeling that whether I am getting broken while delivering, doctor. 17-year-old girl presents with severe abdominal pain, heavy vaginal bleeding. She took misoprostol 2 days ago but has not passed any tissue. Her BP is 90/50, heart rate is 120. She appears pale and diaphoretic. How do you want to manage? Perform ultrasound to look for any retained products of conception, ROC, is what you need to remember. 28-year-old, elective abortion at 8 weeks of gestation, mild abdominal pain, heavy bleeding in the first few days. No evidence of infection. What do you want to do? So offer the patient counseling because she is very stable, and support resources. 30-year-old woman presents to emergency with heavy vaginal bleeding, severe abdominal pain, positive pregnancy test 6 weeks ago. Her BP is 90/50, heart rate is 120, ultrasound shows gestational sign, no fetal pole. What do you want to do? Schedule the patient for a dilatation curettage. So, incomplete abortion or missed abortion is a possible diagnosis considering her signs and symptoms. The next step is to perform D&C to remove the contents of the uterus and prevent any further complications. The last 3 questions of today's wonderful evening with all of you, doctor. I thought to take a break, but there's no point on a festival day, because festivals come for us to reinforce our energies, to restart our preparation basically. So tomorrow I will have a long class, and we'll try to continue our discussion of the AIMS previous year question bank. So 28-year-old woman presents with vaginal bleeding, cramping at 10 weeks of gestation. She reports that she had no complications during her pregnancy. Vitals normal. Ultrasound shows a fetus with no cardiac activity. What is the next best step you want to do? So there is a missed abortion. Always whenever missed abortion sign symptoms are there, the next step is to perform dilatation curettage procedure to remove the contents of the uterus, is what you need to remember. 25-year-old woman with vaginal bleeding, lower abdominal pain, she is 14 weeks pregnant, BP 100/60, heart rate is 90, fetus and no cardiac activity, but enlarged uterus. What is the next step? So you need to fit the whole thing into a diagnosis. So once more, this is a missed abortion with enlargement. The next step is to do dilatation and evacuation procedure and remove the contents of the uterus. 35-year-old man with the history of asthma, which is worsening during high humidity, elevated eosinophils, Aspergillus fumigatus, IgE antibodies. What do you want to do with him? You need to give systemic steroids. So it is an allergic bronchopulmonary aspergillosis, ABPA. There's a criteria for that. The next step is to give systemic steroids to reduce the inflammation. So the last question for the evening is, 40-year-old woman with history of cystic fibrosis presents with persistent cough, shortness of breath. In spite of giving antibiotics, her symptoms are continuing. Fumigatus antibodies are positive. Serum IgE is elevated. What is the next step in management? You need to do bronchoscopy, bronchoalveolar lavage to confirm the diagnosis of aspergillosis and accordingly guide the management, is what you need to remember. So with that, we come to the end of today's evening, doctor. Tomorrow, we will really take up Dhanush and arrows, prayer, Lord Rama, and then continue our fight. Thank you all for attending this wonderful evening, and see you all tomorrow. Thank you.